The purpose of this intervention was to understand patients' experiences after engaging in a 5-session psychological intervention for chronic pain that was delivered in Henry Ford's internal medicine clinic. Of the 30 participants who were recruited and randomly assigned to our intervention group, 23 participants completed all 5 sessions and then underwent exit interviews that queried about components of the intervention that they liked or disliked, as well as any suggestions they had for improvement. In terms of the way the intervention was delivered, the majority of participants believed the intervention is likely most beneficial if all 5 sessions are completed, with the ideal session frequency being between twice per week to twice per month. However, of note, 65% of participants said that the specific session modules and other delivery components, like frequency and duration of sessions, should be tailored to individual schedules and needs. So this is just something to keep in mind for future versions of this intervention. In terms of intervention components, the graph on the left shows each session component listed in order of most favored or found to be most beneficial to least favored or found to be least beneficial. The graph over on the right lists most of the suggestions participants had to improve the intervention. 2 of the components that all participants found beneficial were pain psychoeducation and then spending time in the final session reviewing all the strategies that they had learned during the intervention. However, some patients suggested that having more written or electronic materials to refer to at a later time could facilitate more practice of the strategies after the intervention was over. Some participants also noted that pain psychoeducation and other educational components could have been better explained during the intervention. So keeping these 2 suggestions in mind, something we might consider in a modified intervention is perhaps providing more materials that are possibly even adapted to varying levels of health literacy to then hopefully facilitate better learning. And then also we want to make sure that enough time is spent in each session clarifying any questions about new concepts that are being learned, as well as reviewing any strategies that patients might have on previous skills that they learned. Diaphragmatic breathing is one of the mindfulness activities that we offered in our intervention and was universally found to be beneficial among participants. However, other mindfulness-based strategies that we had offered, such as leaves on a stream and sensory grounding, were not necessarily found to be as helpful. Several participants specifically asked for more mindfulness practices. Therefore, a modified version of this intervention might offer more mindfulness strategies that could essentially allow participants to develop a mindfulness practice that works for their unique pain experience by giving them more strategies to pick and choose from in their proverbial toolboxes. Some participants also requested a physical exercise or stretching component be included in the intervention, which may help diversify the skills they're learning and help participants increase their sense of bodily awareness, thereby strengthening their mind-body connection, which is an important part of chronic pain management. So a future intervention might consider spending more time on skills with physical or mind-body components. Some participants noted that they would have preferred having a better understanding of what the intervention would look like before beginning. So making sure to provide an overview of the intervention could help set realistic expectations for pain management in these patients. Several participants also suggested that it would have been helpful to have set specific goals each session for weekly homework assignments. So weekly homework assignments allow participants to practice the strategies outside of session, and then reviewing that homework in session can sometimes help clinicians identify gaps in patient understanding of the techniques. So given that goal setting might help hold patients accountable for practicing their skills, this could be a useful modification to a future version of this intervention. Lastly, more than a third of participants requested an option to check in with the clinician at a future date. So perhaps a modified version of this intervention can offer a 1, 3, or even 6-month follow-up session or phone call to help facilitate skills practice long after the intervention is completed. Overall, all participants in our intervention found some or all of the intervention beneficial, which suggests that brief interventions for chronic pain delivered in a primary care setting is useful and feasible. It's important to find alternate ways of treating chronic pain, given its very high prevalence and many barriers to traditional treatment. So future research can evaluate whether modified interventions, which take into account these patients' perspectives, would improve treatment adherence and outcomes.